What is shoulder dystocia? Shoulder dystocia is a complication that can occur during vaginal delivery. It is an obstetric emergency. Shoulder dystocia commonly defines where you have the anterior fetal shoulder dropped behind the symphysis pubis and fail to deliver using normal exerted downward traction and maternal pushing. It is bony problem, or sometimes you may have the posterior shoulder where it is actually trapped behind the sacral prominence of the pelvis. It is impossible to predict whether shoulder dystocia will happen, but there are some things that make it more likely, including when you are I'm talking about the risk factors: experience shoulder dystocia during a previous labor, or having a large baby, fetal macrosomia, or having twins or multiple babies, are very overweight, have diabetes, have had induced labor, or other interventions are used during labor, or the last is the operative delivery. Shoulder dystocia can also happen if the labor goes very quickly or very slowly. However, over 50% shoulder dystocia cases are not predictable and you have no risk factors, so you need to be prepared for the possibility of shoulder dystocia at every delivery. It is a clinical diagnosis that should be made promptly. Immediate recognition of shoulder dystocia is essential. Signs includes head recoils against perineum or the turtle sign, spontaneous restitution doesn't occur, failure to deliver with expulsive effort and usual maneuvers. Several obstetrical maneuvers may be performed to free the shoulder. This requires a team approach in which effective communication and leadership are critical. It occurs approximately 1% of births dystocia can caused by impaction of the anterior posterior shoulder during vaginal delivery. So my name is Annalise Routine, and today I'm going to perform a demonstration about shoulder dystocia. So first I have to identify the clients, introduce myself, and explain the procedure. Hello, good afternoon. My name is Annalise Routine and I am your state nurse for the day. So may I know your name, please? Fedi, what is your date of birth? Okay, so what name do you prefer me to call you? So I'm here today for the emergency management for shoulder dystocia. So it involves me inserting my fingers inside your uterus to assess the position of the shoulder position of your baby, which is now in anterior position. So is that okay with you? I will place you on a table where I can perform this. So is that okay with you? Okay, great. So let me wash my hands and I put on my gloves and I'll be back. Okay? Okay, so ready, I'm back. So I'll just close the curtain to give you privacy, provide privacy to the patient. Position involves three kinds of position. This is the dorsal position, the dorsal recumbent position, the Sims position, and the knee chest position. So I need to ensure that the mom is towards the end of the bed so that we can get room to actually access and perform any maneuvers. Okay, so the mom would need to come down to the bottom of the bed in order to perform Macroburst Maneuver. And I will probably ask another assistant to help me perform this. Okay, so I will drape the mother. So what we are going to do is to drape the client, expose only the gynecological area. So the first thing I need to do is to ask for help. So I need my senior midwife to assist me and to call for help if necessary. And also the senior obstetrician and the senior anesthetist, if the mother has some pain, needs some pain management. And also I need a pediatrician for resuscitation. And also I need a scribe also to document all the necessary documentation from the start of the shoulder dystocia to the management and until the delivery. So I need to evaluate the possible episiotomy to increase the anterior posterior diameter of passage. So early in the delivery, the mother's legs are placed in stirrups in Macroburst position, and so at this point, episiotomy is cut to assist me in this delivery. So my assistant will help me, and at this point, I will ask the mother to flex the legs, flex her legs, to do the Macroburst Maneuver. So by doing that, I think this is the first option. Hyperflexion of legs with malabduction and internal rotation. The patient's leg should be flexed all the way back so that her right thighs are against the abdomen. So these movements rotate the pubis symphysis and flattens the sacrum to relieve obstruction. This may be sufficient to relieve obstruction in up to 42% of the patient. If the shoulder dystocia persists, if the shoulder dystocia persists, then move to the next. Okay, Fedi, so I want you to flex your legs towards the direction. Robert maneuver actually do is that you are flexing the leg flex at the hip and abducting the hip so that you are opening the pelvic cavity. Roberts actually does is flatten the sacrum, and it also rotates the symphysis pubis anterior in an anterior direction, so that it actually widens the pelvic cavity, and in the most cases that might be enough to actually free the baby once we've done the Macroburst maneuver. If Macroburst maneuver is working, so let's proceed to another maneuver, which is the we have to insert pressure. We have to apply Suprapubic Maneuver or the Mazzanti maneuver. If the maneuver isn't working, so I need to proceed to the next maneuver, which is the pressure or the suprapubic pressure or Mazzanti maneuver. So I will apply pressure just proximately to the pubic symphysis, either continuously or rocking motion. Apply normal and gentle traction, attempts to realign or rotate the infant. This maneuver ducks and rotates fetal shoulder to disimpact the anterior shoulder. So for entry maneuver or the Robbins maneuver, or we call it reverse ward screw maneuver, it is done by applying pressure to anterior aspect of posterior shoulder, causing movements of shoulder into more oblique position in the pelvis, or the Robin 2 maneuver by applying pressure to the posterior aspect of the most accessible shoulder, anterior or posterior. It is done by exerting fingers behind the posterior aspect of the anterior shoulder and rotate the shoulder towards fetal chest. Attempts to insert a hand and align the posterior shoulder to accomplish delivery. If none of these maneuver work, an episiotomy is cut, and episiotomy is a surgical cut made to the opening of the vagina to allow more room and better access to the posterior arm. So remove posterior arm by sweeping it across the chest and bring fetal hand to the chin, cross and pull out the birth canal and across the face. So if it is not working, so let's proceed to the roll-on force or the gaskin position. This is done by assisting the client to roll onto hands and knees and apply downward traction or pull downward to deliver the posterior shoulder, and can be repeated until the shoulder of the fetus is delivered. If none of these maneuvers work, so the last recourse is to move back or to detach the fetus and move back to the uterus for cesarean section. And lastly, document the procedure.